side of thigh. Just put on the light. Focus it here. Ikadta launa. Can see that he has got big dilated superficial veins here on the medial side. सिर्फ यहाँ है कि ऊपर भी है? ये दो है बड़ी वाली. यहाँ भी लगती है? नहीं, यहाँ नहीं है. सो अच्छा, ओके. यदि खड़े होने पे बढ़ जाती है क्या? हाँ, ठीक है. टर्न ऑफ द लाइट्स. इधर सरको मेरे तरफ. So before moving to lower limb, in 2 minutes we'll just see patency of IVC and iliac veins. We'll do quickly identify and confirm. It just takes 2 minutes to see it, but it saves you sometimes. Sometimes there are masses in the pelvis region, or there are old thrombus in the iliac level that may give rise to the varicosity. So we see the external iliac vein and artery and just confirm the flow. So normal flow, this part is normal. We'll go to the lower limb, select the probe, select the setting. So that is the common femoral vein and artery. This is the long section. This is artery laterally and the vein is medially. Can see a large vessel coming from below the anterior abdominal wall, and this is entering it here, going it. थोड़ा नीचे करो इसको, और नीचे कर लो. हाँ, आराम से लेटो. पैर बाहर घुमाओ. So that is the saphenofemoral junction here. This is the Mickey Mouse sign, it is called. Femoral vein, GSV and the femoral artery. You can see that femoral vein. There are some nodes here, and very rarely the large nodes, they just compress this GSV and then causes dilatation of GSV. You should look for them whenever. These are the superficial epigastric vessels. So we come back here, make a long section, artery laterally, vein medially, and that is the junction there. You can appreciate that there is a wall here, small wall. That is superficial epigastric, very small vein, and this is the GSV. So with minimal probe pressure. We just try to see the पैर ढीला रख दो, आराम से रहो, हाँ टाइट नहीं करना. Now we see the normal direction of flow. पेट फुलाओ. Oh, see that he has got gross reflux. You don't need anything to do. Even the clinician may have identify, but nowadays they don't do clinical examination and just do advised Doppler just for the sake of confirmation. पेट फुलाओ, छोड़ दो. A severe reflux. You don't need to measure time for this. इसको ऊपर कर लो, ऊपर ले लो, ले लो ऊपर. हाँ, यहाँ से ऊपर ले लो, अंदर की ओर पकड़ के रखो, पैर ढीला छोड़ देना, आराम से रहो. सर नहीं नीचे उठाना, हाँ सर आराम से रखो. So that is the junction, that is superficial epigastric. We are coming down, that is GSV. We'll try to trace the GSV, adjust the focus so that we see that GSV nicely. This is going medially. I'll try to see whether there are any tributaries here. Put color, use very minimal pressure. So that is a small, very small tributary entering it. No major dilated tributary here. You can trace it by both means. छोड़ दो उसको, पैर थोड़ा बाहर निकालो, हाँ ऐसा रख दो, ढीला छोड़ दो. You have to externally rotate at the hip joint so that the medial side gets exposed and you can see it nicely. See that this is one tributary coming here, that could be the accessory. Can appreciate here, it is entering here and going. See, it is more superficial than this. So at the time of entering it, they will come into this fascia and enter the GSV. It's quite dilated GSV. I am almost at the level of knee joint. So there are no major tributaries. We will complete our survey of the deep veins, whether they are normal or not. We have to ensure that this is primary varicose veins or primary incompetence. Steer it other direction. Can see that all four SFA, SFV, profunda femoral vein or deep femoral vein and deep femoral artery. So they are very nicely filled. Now because he has saphenofemoral incompetence, we need to know whether there is any deep venous reflux. पेट फुलाओ, छोड़ दो, फुलाओ, छोड़ दो. See, when I asked him to do Valsalva in the first setting, you couldn't see anything. Now I reduced the PRF to check very low flow and you can see that there is a reflux or deep vein reflux. Full of it, see that, छोड़ दो. We'll do a spectral here and confirm what we had seen. Full of it, see, छोड़ दो. In the earlier patient there was no flow after Valsalva doing Valsalva. Now you see that flow is on the other side of the baseline. So that is deep vein reflux. So again compression, adjust the focus, increase the visibility, compression. So the veins are normal. We'll go to the उधर करवट ले लो. I'll ask him to do almost a prone position to see the popliteal fossa, see it in transverse, identify vein and artery, that is vein and artery, vein and artery. That is the short saphenous here. These are the heads of gastrocnemius. That is superficial fascia, and this is the short saphenous. Again, like GSV, it is in the fascia. You can see that. Now it is dipping down to go enter into the popliteal vein. So, but can appreciate on long section the popliteal vein, the popliteal artery. This is the vein. This is the artery. This is the vein. Just confirm. Invert the steer. Reduce the box. So there is some flow. I will augment the calf, and you can see there is augmentation. Okay. So here in the superficial plane you can see that varicosity is at the point of swelling he was pointing to. There are dilated veins here. We'll follow the GSV and try to see whether they are tributaries of the GSV. This is GSV and this is the tributary, and that is producing here superficial varicosities. ठीक है, सीधे हो जाओ. I want to see the medial side of left leg, so I ask him to turn to supine position and then follow the GSV. If the GSV is dilated, you can follow it. थोड़ा पैर और बाहर घुमाओ. हाँ, of them are in superficial plane, and here it is entering the deep plane. See that I am almost at the popliteal fossa. From medial it has gone to posterior, the superficial varicosity. That was what I was referring to. There is no definite course from where the perforator would go, or from where the varicosities would develop. So he has SFJ incompetence, and the perforator is posteriorly. You can see this is popliteal vein and artery. These are tibial and we are at the popliteal fossa, and we see that here this is the point of perforation. This is the point. It is entering superficial to deep. It's more than half a centimeter, and you can see on B mode also the blood is flowing across. We'll try to see. So more than 3.5 millimeter is taken abnormal, and at rest also you can see there is some reversal there. पेट फुलाओ, छोड़ दो, थोड़ा कॉम्प्रेस कर, compression. See that before compression the flow was going away from the probe, from superficial to deep, and after compression you can see that there is a sustained reversal. Very big perforator, it has to be incompetent. Same thing you can confirm on spectrum also. At the point of entry from superficial to deep fascia, just put the spectral gate and compress. See, otherwise also he was showing incompetence. This, but this is the normal direction of flow, and after Valsalva you can see that there is a significant reflux there. So we'll see any other perforator are there. We come back to the medial side again, and this is very big perforator here. Clinically also I think we can feel that what it is called, the clinicians they palpate it, and sometimes the senior clinician used to identify and label, try to see it here that I am feeling a perforator here. They are so big that they can feel it where it is going. So gross varicosities, the GSV what we were seeing here, that is all the tributaries, they are dilated and enlarged, become tortuous due to long standing stagnation. So we'll complete the deep venous evaluation by seeing the tibial veins at the ankle, just doing long section. That is the artery. थोड़ा malleolus ला compress कर. हाँ. Compress. Yes. So that is the vein down. The red one is the artery, and a vessel that fills for momentarily, that is a posterior tibial vein. So there is no deep venous thrombosis. We'll see the anterior tibial. So you can develop your own what you can say protocol of examining, or otherwise once first you finish the deep vein, and at the same time just keep an eye where you are seeing perforators or this thing, and then do the superficial vein evaluation, because it takes more time, or you can do both simultaneously. So that is the vein above and artery below, that is anterior tibial. बैठ जाओ थोड़ा, पीछे सरको. Yes. अच्छा उधर भी चालू हो गया क्या? ओके. So here at one more point it is piercing. This is a point where it is piercing again, one more perforator. You can see it is going in the muscle. So the direction is not described. It finds its own way. See, there is large intravenous perforator. They are quite large. They are going posteriorly. This is one more down below. See, it is entering the fascia here. We'll check whether it is incompetent or not. Quickly compress, relax. Otherwise also compress. Not showing much reflux. Okay. And reduce the size. Just focus at the point of entry. Compress. No reflux. But the size is quite big. If you measure it here, almost half a centimeter. So I will try a proximal compression here. Still the direction of flow remains same. Here the red is going down. If you see the spectrum on the side of the screen, red is going down, so it is going from superficial to deep. There is no reflux in both maneuvers, either proximal compression or distal augmentation. Still, because of its size, it is a significant perforator. Okay. We have any more case? Okay. अब बैठ जाओ आप.